Hello, good evening. Good evening, everyone. Just wait a few minutes to start.
Okay. Good evening, Dr. Cole.
Good evening,
Yeah,
Dr. Oiwal. Good evening,
good
everyone
evening.
joining in.
Let me try and see if I can share.
Okay,
Just
your slides.
to
Okay,
enable. Yes, you need to enable me.
okay. Can you share now?
Let me try.
Good evening, everyone. Welcome to another webinar series on skin NTDs, skin neglected tropical diseases. We've had about 7 or 8 so far, and it's been quite interesting. So we're going on to one of the next skin NTDs, which Dr. Oiwa will be talking about today, and that is endemic treponematosis, also known as Yaws. So if you have missed any of the previous webinars on other skin NTDs, they are all on YouTube, on my YouTube channel, so you can actually watch them there, or if you would like to rewatch some of the ones that you had, attended, you can, watch that. And you can also share the links with other people. It's a good educational resource for skin NTDs, and it's, public, it's available for everyone online. And we hope to continue with this series and complete all the skin NTDs, talk about all the skin NTDs, and also at the end of the webinar series have an outreach, which will be kind of like a practical application of what we've been learning about over the last 2 to 3 months. Okay, so once Dr. Oiwa is ready, well, we'll just wait a bit to let more people into the meeting room so that we can have a good number before we start. Yeah, we can see your
So, Dr.
screen
Cole,
now.
okay.
So you just need to go to your presentation. Yeah.
Okay, so I can start now.
Yeah, but we can't see your presentation. So you need to go to
Okay,
your
you can't
presentation.
see the
We can
slides.
see your screen, yeah. We can see your screen, but your presentation is not yet on the screen.
Just a moment. Just a moment, please.
Okay. So again, anyone, if you have questions, comments, or contributions, please put them on the chat box, the Q&A actually, and we will answer the questions at the end of the presentation. Okay.
Moment, please.
So everyone coming in, you're welcome once again. We're having a webinar on skin NTDs. Today we're talking about Yaws, or endemic treponematosis. So Dr. Oy will be taking us through Yaws, or endemic treponematosis. I would like to just, as we're waiting for him to for the screen to come up, it's not something that is so commonly seen. personally, in my own personal experience, I haven't seen so many cases of Yaws or endemic treponematosis, but I'm sure other people may have other different experiences with it. But it is still quite common in some parts of sub-Saharan Africa and some parts of Nigeria. So we'll get the latest stats and updates from Dr. Oivo shortly. So we're hoping to have more. Okay. Join in. So if there's any, maybe you could also consider sending it if you have challenges with displaying it. Perhaps you could send it and we could try to help. Hello. Okay, just open the PDF. Is it in PDF or PowerPoint format? You are muted, Dr. Oiwo, in case you are speaking.
Okay, so maybe what I will just, can you hear me now?
Yes, I can hear you now.
Yeah, it's actually in PDF formats, and I suppose my screen should be seen now. Can you see my presentation now?
No, we can see a folder, that has all the photos and all, but we can see the PDF, but it's not opened. So can you click on it and open it? Are you seeing it from your end?
Yes, I am. Just a moment. Maybe I'll just forward it to you then. I'm forwarding it to you.
Okay, via email?
No, WhatsApp.
Okay, no problem. I will send it to my computer. Just send it to me. I'll send it to my computer.
Okay. So sorry about the delay, please.
No problem. Sometimes technical hitches come up and that's sometimes inevitable. Okay, so I'm just downloading it and then I'm going to try to send it to my computer as well. In just a moment, please. But you can just start talking about it before your presentation comes up.
Basically, so that we don't waste too much time. Once again, my name is Oiwo. I'm a dermatologist, Ura specialist. Today we'll be talking about an important yet NTD in Nigeria. That's by tracing, it's about 1,500 years old, according to some dating of bones in faraway Kenya. Basically, one of the syphilis kind of, we'll call it, it's a syphilitic infection, but of course, as different from the other siblings of the same family. It's basically it's non-venereal, non-sexually transmitted, and because it is non-sexually transmitted, We also have pictures on the screen. What we'll talk about today, if indeed we actually seen any case of yours in our practice, I would like to see who may possibly or seen yours, so that at the end of the presentation with that another question, if indeed the questions had said yes or no to are indeed yes or no. So as wait for the presentation to come on, to add again that it's one of the two diseases that has been marked by WHO for eradication. Interestingly, Nigeria has that for eradication, guinea worm and yaws. And it's interesting to note that it appears quite silent. And the question we need to ask ourselves is it really as silent it appears? Is amidst other skin infections that present the way it does? Is it also that we cannot pick it up or diagnose it as appropriately? So this session will basically just look through the objectives of knowing the extent, the spread and distribution of yours. Then would also want to look at the transmission and clinical features of yours, as well as look into the diagnosis, management, and strategies that are employed in the public health response on yours. And we would have quite a retinue of documents to look into. Just want to check, Dr. Cole, any headway at all, please? Hello?
Sorry, I am actually trying to download it. It's taking a bit longer than expected, but I think I finally succeeded. So I'm going to have to share my screen. Okay. Okay, so can you stop sharing yours so that I can share my screen?
Okay, so sorry.
Can you see my screen now?
Trying to, yes. Yes, there are 94 slides, but majority are pictures that would actually guide us on how best to pick this in the various ways. So like I've talked about, we basically have moved to the fourth slide. And from there, we shall proceed to knowing the clinical characteristics after we have looked at some of the epidemiological features of yours. So in terms of the epidemiology of yaws, we do know that yaws is common in Africa, Southeast Asia, in the Americas, and especially in the West Pacific, especially Solomon Island, and a few other areas. Those are areas that have reported yaws in the past. So as we can see on the slide, these are just the retinue of documents we'll have to glean through for this presentation. Next slide. So if we look very closely, I've asked this question: how many of us have seen yaws? How many of us have managed yaws? So let's just keep our questions. We could even have that in the comment section so that we'll see what the comment looks like. So we'll just go to the next slide. And of course, another question to find out whatever our answer is, we need to do some root cause analysis. Is it that we really do not have the data available, or that we do have the data available, but there are a few problems as I highlighted here, which this presentation would talk about at the next slides. So at the next slide, we'll see that some of these overarching targets of WHO need to also be looked at and concentrated on. So these are some of the overarching targets. So next slide. So these are just more like reminding ourselves of where we're coming from, that Yaws in itself is not a separate entity. It is one of the NTDs by WHO. It goes by various names, depending on which part of Africa. Interestingly, Ghana appears to have quite quite a burden of Yaws, and so we'll see some of the names there that appear Ghanaian, some French, and so it's good to know that it's a chronic infection. It comes on and off, and is by Treponema pallidum petenue, and it's good that early detection will be fine to prevent the disfigurement that usually takes place in 1 out of 10 of the patients. And so going on to the next slide, we'll be able to also have a look at some of the epidemiological features of Yaws that talks about the frequency in various places. Next slide, please. The frequency in various parts of the world and the various names depending on the type of the presentation. For those that have managed Yaws, we see that the one that occurs on the sole of the feet, it makes the patient tends to walk like crab because of the pain. There's this crab-like gait that comes with it. So that's why it's called crab yaw. So a few other presentations will see more. Then it's good to note that hair loss is not usually a feature, and involvement of mucosa is secondary. So the next slide would we've talked about this. We've mentioned that it's 1,500 years, and in the course of Yaws was first noted by the man Aldo Castellani in the year 1905. And India is one of the countries that's eradicated. Ecuador, I intentionally put it in red. If we see most documents, India is the most popular of the nations that's eradicated Yaws. So next slide. So once we have this basic knowledge, we want to know who and where. Of course, in the resource poor setting, like I mentioned, low economic, socioeconomic area, poor hygiene, particularly it occurs more in children. Next slide. And these people that it affects, if care is not taken, it can progress one from the person, the other person who contracts it, as it were, gets that by direct contact with the fluid or by the rash, especially that yellow crust that tends to cover it is filled with very active components of the Treponema petenue organisms, and typically incubation period is between is there about maybe like 3 months. Next slide. And of course, we know that scratches and abrasions here and there tend to also increase the risk of this infection, and it can be latent at any point in time. And that is the question I asked. The fact that we do not see it in Nigeria, the last time this became very popular in Nigeria was in 1950s in Enugu, where UNICEF and WHO went into mass drug administration using benzathine penicillin. And since that time, between 1956 and 1970, the cases appear to have gone down. So what we have in recent times are just suspected cases in various parts of the nation. And it's good to know that, yes, some of these states that are not reporting it, is it that we don't have it, or we have it in latent forms, but the facilities are not available to diagnose the latent forms. Media had done quite some work, and I looked at the ratio of the active to latent, 1:6. Next slide. And we would also note that there are 3 different types: primary, secondary, and tertiary. And it's good to know out of all of them, which of them is actually infectious, which is not infectious. As we can see, the primary and secondary are actually the infectious and contagious type. Next slide. And we know that the tertiary affects the bone, sort of causing what looks like a bow kind of shape for the bone. So next slide. Would see going on that the various parts of the world have been classified. Nigeria appears to be in Group B, previously endemic with unknown current status. There are countries that have known status. There are countries that have never even reported Yaws at all. Next slide. so with this knowledge, of course, we see this very very well represented in the Global Observatory of Yaws. Would see that what we have in Africa, we have more of formerly endemic in Africa. Next slide. And in Nigeria, basically, if we look at the strategic plan, we would see that yeah, maybe just 1 or 2 states, but in recent times, we have at least 5 to 6 states that have reported suspected cases. And so this data just shows that over the years, various parts of the world, Papua New Guinea, Solomon Island, Vanuatu, are areas of the world that have a very high burden of this disease, of this infection. Next slide, please. Because it must be borne in mind that to have an infection would also mean that the infectious stage can progress to the disease. Next slide, please. So we've mentioned that media had done quite some work and had looked at active and latent disease, and there are about 89 million people living in your endemic districts as of 2012. Next slide. Next slide, please. Yeah, it tends to be going backwards, not forwards. Okay, thank you. Yes, so that's that previous slide. Would see that even in the literature, there's not too much documentation in the literature as to Yaws. The last that brought Nigeria back to Yaws was in 2006 by Akogun et al. That reported that in the northern part of Nigeria. Noruka et al. Also looked at that thereabout in around that same area, where she compared all previous skin diseases with the skin diseases of the time of the review, and found out that Yaws was not part of the infections diagnosed in the University of Nigeria Teaching Hospital. Next slide. So the question now is this: since we have talked about the incidence in Enugu, the next slide will now tell us, so we'll move to the next slide now, and this will tell us what the situation is as of December. And we can see that these areas in green are areas that have reported suspected cases of Yaws. The next slide we'll now see that so this year, this is the current status of Yaws, the current map of Yaws in Nigeria, 13 states, but of course the active ones are the ones highlighted in red. And you see that majorly it appears from the middle belt to the northern part of the country, even though Enugu appeared to have been the first place in 1956. Next slide. So whichever side we sit on now, is it that Yaws is absent in other states of Nigeria, or that Yaws is really present in other states, but in latent states? So whichever side you are, let's pull it at the end of this presentation and we'll arrive at the meeting point. Next slide. So we need to remind ourselves of the target of the NTD program of Nigeria, which aligns with the target of WHO to ensure that Yaws is eradicated by 2030. Next slide. While we are talking about, Yaws not being present, some samples of patients that had HIV had been looked at, and when it was looked at, they found out that there's some percentage of seropositive samples there, which tends to suggest that it's likely that we have them, but they basically may just be in the maybe latent phase. So we need to do a lot more detailed work on it. Next slide. So the clinical features, Yaws can occur as flat rash, raised rash, lumps, as we can see here. It can even occur as an ulcer. It can occur presenting as a lump on the skin. And this slide shows example of the skin NTDs that can present in the various forms. Next slide. So it's good to have a knowledge of this or the various ways they can present. Oftentimes what we see is we see patient presenting at the level of the ulcer, which should really not be the case. Because when you speak to people, they say, oh, the classical case is a volcano ulcer. But we do not want the patient to get to that case, which is why we need to increase our level of suspicion, reduce the threshold, so that we can be able to get a lot more. So the question we now ask when we see some of these things is to find out, did it start as a painless lump? It usually starts as a painless lump. Of course, we know that over time it can get infected and pain can come in there. But typically the floor is usually, that's the second line there. You'll see that is red, moist, clear, and can be crusted. That's a yellow crusted covering. Next slide. So in the course of these clinical features, we'll be able to see some of the pictures, the various presentations, either as flats or flat rashes or lumps. Next slide, please. So they can present in various stages. They can present as wax-like lesion. They look like, they can present like what? You know, at times we see them and say, oh, this is what. They can also present as ulcers, then the various stages that we've talked about. Next slide. So if we see the various morphologies of the rashes, it can present in various ways. It can even present like this very big, what I do not want to use the technical name, but it's condyloma, like cauliflower, like it can present as cauliflower. And if care is not taken, it can extend to involve the nose with destruction of the nose and even the bones. So those names, gangosa, gondu, those are indigenous names that various countries in the world where that has occurred have called it. Next slide, please. So they can have, you can also go beyond the skin to affect the joints, affect the eyes. It can even also affect the nerves, causing some level of disc atrophy, some level of blindness or varied level of visual impairment. Next slide, please. Then, of course, there can be auto amputation of the digits that are affected. So we can see that it's not just leprosy and a few of these other causes of auto amputation. Yaws also comes to mind as one of the rare causes of auto amputation. And of course, we do know that when we are making this diagnosis, we need to know who is a confirmed case, suspected case. All of these features, patient living in an endemic area with a typical rash, we say is suspected case. When the patient is tested, patient becomes confirmed. And contacts are those who have frequent interaction with the infected person or the rash, and they can include playmates, classmates, and a few other people. Next slide, please. So the set of pictures we'll see now would, next slide, set of pictures we'll see now would see that there are various forms. And when we see these pictures, I want us to cast our mind back to whether we've seen patients that are presented with this type of rashes. You know, we see, if you see this on this slide now, it can affect, typically it affects the hands, legs, upper and lower limbs. And usually starts with, at times it can start with a lump from the uppermost left of the screen. Then we'll also see it that the center can get, the center can I want to avoid using the technical terms now. We can see that the center can form an ulcer and it clears out in what we call the volcano kind of rash. And we see these other areas, we'll see them can also affect the palms with dark palms. Next slide. So this picture shows this child that was picked and treatment started, and we'll see before and after. It can affect any parts of the body, like I said, commonly on the upper and the lower limbs, but in this case can affect the face. Next slide. So this is a patient with a father who has multiple yaws. So if we look at this rash, we see that it looks like some of the rashes we may have seen. But again, what differentiates them is the fact that patient lives in the endemic zone, other histories associated with it. Next slide. And like we said, it's typically painless, but of course we know that once there's infection and some level of manipulation, we can have it become painful if it becomes secondarily infected. And we'll see, yes, on the right of the screen is a poster, but I feel it's also fine to see the various ways it can present on the body. Usually occurs as a group of 1 to 3 rashes. Next slide. So as we see on the right of the screen, the very red, clear center, then on the left of the screen, we'll see what some of us, in the local parlance they call eczema. But again, we do know that it is rough. Some may also see, oh, this looks like vitiligo. This looks like leprosy. This looks like a few other things. So history and examination will really also clear this out. And if we look at this, the surface will be rough as compared to what we have in vitiligo. Then we also see that other parts of the skin may also be affected. Then history of endemicity would also help us out. Next slide. So these are the various presentations, various stages. Starts as a lump and the lower border. We'll see that when the ulcer starts forming, it tends to dig deep inside. So of course, we also know that there are other ulcers that can present like this. But like I said, once we have history and adequate examination, we'll be able to clinch the diagnosis. Next slide. So this is the bone being involved. Like I mentioned at the beginning, this is at the tertiary stage of Yaws, and we do not hope that patients present at this stage. When patients start presenting at this stage, it tends to become a little too late. So the aim of this presentation is for us to pick them on time. That suspicious ulcer that has been there for months in a patient who lives in the rural area, please consider Yaws as one of the differentials. Next slide. So there are other skin NTDs that can present with ulcers too. And so this slide just shows us the various NTDs that can present with ulcers. The very notorious one out of them is Buruli ulcer that tends to appear as though the entire skin is being pulled off. You can see leishmaniasis. We also see tropical ulcer. Even leprosy can present with ulcer on the sole of the foot. Other, to mention Buruli ulcer. And it's good to note that about 40% of cases of ulcers that are said to be yours eventually turn out to be ulcers of Haemophilus ducreyi. That's chancroid. Next slide. So this history would guide us. Usually they come as a group of 1 to 3, and the group of 1 to 3 lumps in multiple sites or maybe in a particular site. It has a yellow covering. There's a particular slide that would come maybe in a few slides to come that would tend to test what we have seen so far. Next slide. So there is also the attenuated Yaws that could also present with some of the features that do not look typical and is less contagious. And it can present with just a small eczema, like when I use eczema now in the local parlance, that whitish discoloration of the skin. Next slide. And we also find this in the skin folds. So what is WHO doing to eradicate Yaws? It's basically highlighting the Kigali Declaration, cross-cutting approach, supporting countries with training materials, as of course, at the end of this presentation, would appreciate the Federal Ministry of Health for some of the training materials that is used for this presentation. Of course, supply of drugs, partnership with NGOs, Then integration of multiple skin NTDs, that one stone kill plenty bird approach can be used to take care of them. Next slide. So there are a few challenges. The challenges are that, one, especially like I've mentioned, is it that the complete epidemiological information on the location of the cases is not that clear, or that, of course, there are some of these populations where this occurs, some can be nomadic. And so picking them and following up this patient can be a problem. Necessary logistics also have also been highlighted as a problem. Then the issue of adequate training for human resource. And to bridge this gap, this is why the International Foundation for Dermatology and International League of Dermatological Society, in collaboration with Nigeria Association of Dermatologists, is championing this training session. Next slide. So these are some of the possible operational challenges that Yaws have faced and is still facing in the parts of the world. Basically, diagnosis is by history, examination, then we'll go test. Previously, yes, we need to do a dark field microscopy, but in recent times, the diagnosis now has moved towards rapid diagnostic test kits that we'll see in the subsequent slide. Next slide, please. So diagnostic test kits now is the order of the day. Either you want to use the treponema based or the non-treponema based test kits. And when we're doing all this, a few knowledge of some of the various entities that present alike will also be of help when we see these patients before we start deploying these rapid test kits that are not so much in abundance in this part of the world. Next slide. So we would see that various tests over time have looked at rapid diagnostic kit. There's the LAMP4 Yaw that is looking at loop-mediated isothermal amplification, but WHO is making use of rapid diagnostic test kit. Next slide. So rapid diagnostic test kits, the one that is used in Nigeria is the SD Biolin 3.0 for screening, then the dual pathway test, that's DPP, for confirmation. This picture just shows this rapid test kits that this worker is using. Next slide. This is courtesy WHO. Next slide. So we have mentioned this. So this is SD Biolin test kits. Basically, to do this, we need a drop of blood with 4 drops, control line and test line. So this is positive. Next line. Next slide. So we'll see the negative. Then we'll go to the DPP. Next slide, please. Yeah, so the dual path platform is for confirmation, and we have this presently in Nigeria, though quantities are not that much. Next slide. So basically the same, as different from SD Biolin. This has 2 wells. One of the wells where you put 4 to 5 drops, then the other well 1 or 2 drops of the buffer. Then you put the prick, needle prick, you take the sample from the needle prick. The positive test is when this has ability to test both treponema and non-treponema, as well as putting controls into consideration. So these are various forms. Next slide. So we'll see that the control line, the positive lines need to come on, the 2 wells need to come on with the control line for you to say this test positive. Next slide, please. And like I said, these facilities are available in Nigeria. We need to call on the desk officer, that's Mr. Shilo, is really very cooperative in this area and very passionate in ensuring that yours is diagnosed. Other tests that can be used but non-specific are the usual VDRL test, the antibody, yes, antibody test, but this is not popularly used. Polymerase chain reaction is more specific, especially when it comes to area of taking care of resistance and definite confirmation. Then the fingerprint techniques, the whole genome fingerprint technique. Next slide. So we shall move fast now in the subsequent slides, since we have dwelt so much on case recognition. Next slide, please. So this is just the histology for those that have the histology facility in the center, but we do know that majority of these patients will usually come to the health center or even the primary, the general hospitals. Next slide. So at the slide, this slide talks about the various differentials at the stage of the skin involvement, at the stage of the bone involvement. Like that picture that looked at the various ulcers talked about, various skin lesions. It can present like pityriasis versicolor, what is wrongly called eczema. That we had shown the picture previously. If it presents as a lump, there are various other differentials that can look like it. Tuberculosis can also present like it, just like leishmaniasis, that is also being termed as the flesh eater's disease. Next slide, please. Okay, so if it affects the nose, these are the various differentials. If it affects the bones, osteomyelitis, the common differential, tuberculosis, sickle cell anemia. Even if we look at that bone, that sabatibia, like it's called, we have a differential of maybe malnutrition, rickets, and all of that. And that is what most likely people in that area would say this looks like. But if they have looked very closely, they may have found out that this patient had previous history of ulcer that had lasted months. Some may even last up to a year if appropriate treatment is not instituted. Next slide. So I've mentioned this before, 40% of ulcers clinically misidentified as Yaws are usually chancroid. Next slide. So the subsequent slides now, we shall do an average of maybe 5 seconds to 5 seconds per slide. This slide just gives a summary of the diagnosis and treatments. We know that to diagnose Yaws, we need to take, it's possible we can take swab, but in recent times, we just need a prick and the blood is dropped on the RDT kit with a buffer added to it. And we know that the treatment basically is using azithromycin at a dose of 30 milligrams per kg, not exceeding 2,000 milligrams per dose, because it's just a benzathine penicillin was used. But in patients that have, next slide please, in patients that have you may want to use doxycycline in that case. Know that in areas where benzathine, please. Now we know basically the treatment is you give the drug, then wound dressing. You won't azithromycin, dress the wound again. You need to still continue the wound, the usual wound dressing, wound healing, help with tissue regeneration, for so while the next slide is coming on, it's good to also note that when we look at all these patients, the approach also, according to state, also talk about the program of Yaws at the facility level. There's a state NTD coordinator who should be reported to. There's a regional, the zonal NTD coordinator. Then we'll now NTD program desk officer, whose name is Mr. Shiloh. Yes, so based on all that we have seen so far, this is a patient managed in our facility that presented with this ulcer, this rash. On the left of, or the right of the screen, we saw that yellow covering, yellowish crust. Over time, became ulcerated, and with treatment, it tends to have improved done better, swelling subsided, ulcer closed up. Then I'm still following up this patient. So this is a patient I saw about a month ago that is suspected for Yaws. So building capacity is one of the few strategies, which is what we are doing here, clinical diagnosis and a few other things. Next slide, please. So with this capacity, there are also a group of health workers, community health workers, even incorporation of this community of practice is also a strategy by a group of health workers that use mobile application to make diagnosis of Yaws. And like I said, WHO is making use of what is called the integrated approach. And if we look at all of this, those are the skin NTDs that tend to present with ulcers and lumps. So if we're able to pick them, we can direct them. And some of them have the same drugs. And that's the basic principle of integrated case management in the public health response to NTDs and even generally infectious disease outbreaks. Next slide. So we've talked about this. Next slide. We've talked about this before the slides came on. Next slide. Next slide, please. Yes, so epidemiological treatment, the previous slide, please. The epidemiological treatments have also been put into place by WHO, and that looks into 50% of children who are seropositive in hyperendemic area. Once we have that, then you can treat the entire population. If 10 to 50% of children are seropositive, especially the meso-endemic area, we treat the active case, treat the contact, and all children below the age of 15 or 15 and below. And if we have less than 10%, that's hypoendemic, we just treat the active case, household member, and other obvious contacts. Next slide. There is the Mogis approach. Mogis is a place in Switzerland where in 2012, a renewed approach, next slide, a renewed approach to the management of Yaws was made. And this categorically stated azithromycin statum dose, one dose of azithromycin being used for patient. And of course, it's good to note that azithromycin is metabolized by the liver. And so when patients have problems with the liver, it tends to give some challenge with the use of azithromycin. So there comes the other drugs that can also be used. Next slide. Some of the subsequent slides would see the various side effects, possible contraindications. So we've mentioned this dosage. Doxycycline can be used twice daily in patients that have penicillin and azithromycin allergies. So that can be used. Next slide, please. And we do know that treatment failure comes by virtue of rash. You've treated this patient, but instead of the rash to be clearing up, they are increasing in number or getting worse. In the time past, and I call them treatment of antiquities, copper sulfate have been used, arsenic have been used. This was over 50 years ago or even more than. Next slide. So just mentioned to be discarded or for knowledge sake. Next slide. Okay, so treatment failure, I've talked about it. Treatment success, the healing takes place within 4 weeks, there's progress. I've mentioned treatment failure. Next slide. Would see the various definitions of the challenges in treatment outcome. This just talks about the various contraindications to the use of azithromycin. Like I mentioned, azithromycin is metabolized in the liver. And so while we want to do mass drug administration, we are careful to also find out patients with liver problem. We do not just want to give it to them as because it's mass drug administration, we'll just give it to them. So we do not make the treatment of a disease worse than the disease we are treating in itself. This just tells us also, the slide down tells us about the doses. Next slide. So contraindications, side effects, that's what we'll have in the next slide, which we can have at the end of the presentation on the YouTube. Next slide, please. So subsequently, we'll just do 5 seconds per slide now because of our time. So we must manage the psychosocial basis. There's stigma, especially, when this patient has this ulcer that refuses to heal. This patient of mine that says suspected has had a similar ulcer. In fact, it lasted 3 years. It almost took off the limb, as it were. And so basically, when she saw this one, she had to present to the hospital. It's challenging, it's disturbing, and that's a lot of problems. So the doctor needs to look beyond just giving azithromycin. Will manage the psyche of the patient appropriately. Next slide. So, of course, it's not all bad news. It's not all woes about Yaws. We see that India has eradicated it, and we have seen that there are still a few pockets. Because we have a few pockets, it means that it's an infection that we can sit on comfortably. Next slide. The other good news about Yaws is the fact that the single dose approach, the fact that Yaws is focal in some parts of the world, and the fact that, again, the recent interest and resource availability to ensure that the elimination becomes successful. And another important thing is the fact that humans are the only reservoir of this infection. So we know where the enemy lies, in quotes, enemy in quotes. Next slide, please. And so the other good thing is that some have also mentioned that patients with Yaws tend to also have some level of protection against atherosclerosis. These are just scientific works, which is also, well, to make us know that Yaws, the story about Yaws is not all woes here and there. Next slide. Prevention. There's no vaccine yet. Health education is the key. But let the patient know that once you have this rash that has been there and refuses to go, becomes an ulcer, the ulcer has been there. We don't even need to tell them to wait till it gets to the stage of the ulcer. Come to the nearest facility, to the nearest health center. Interestingly, as we speak, the Federal Ministry of Health NTD program desk is developing an integrated manual that can be used across all levels, low-level workers, mid-level workers, high-level workers, but majorly focused on low-level workers to help them in making diagnosis and referral. Thank you. So we'll just move. These are criteria for diagnosis, for eradication. If Nigeria today says that, reports to WHO that we have not reported Yaws in the last 3 years and we are ready to submit to WHO, then WHO would need to also emphasize to check that indeed this information is true. The preceding 3 years, no case of Yaws has been seen, and there's absence of evidence of transmission for continuous years, 3 continuous years, measured by serosurvey among children 1 to 5 years. Next slide. So we're gradually coming to the end of the presentation. All of these next slides now are just to talk about the research questions that need to be looked on, areas that need to be worked on. Next slide. So we'll just do 3 seconds per slide. These are academic discussions, because we know that amongst us here, we have all arrays of health workers. That's why this was also included. Next slide, please. So because we may also be part of the team that may be contacted in our various centers for this. So it's important to have a knowledge of what it takes to interrupt the disease and eradicate the disease. Next slide. So these are just research-based questions on the mass drug administration, on the diagnosis. Next slide, please. And other areas of logistic challenges, other areas that looks into the epidemiology of the infection itself. Next slide. Yeah, next slide. These are just research-based questions that we can have a look at. We can have a look at on the YouTube after this presentation. There are partners that have been working with WHO all over the world, and those are the partners as I highlighted. 5 root cause again for us to look at. After all we have said, are we convinced that we have never seen a case of yaw in our hospital, in our health center, in our facility, or even that pharmacist where you are, that patient comes and says that I don't get this wound, wait on day for 1 year. Instead of you to just say, go and use this drug, please kindly direct appropriately to the next hospital for the next actions to be taken. Next slide. And so this root cause needs to be asked every now and then. Next slide. So mention these areas that talks about dimensions of assessing disease-specific actions. Next slide, please. While we do all of this, we know that yaws is common in people who are poor, who do not have water supply, who have poor hygiene, poor housing. By the time we're able to target each of these epidemiological factors, we would have realized that we are moving ourselves close to the 2030 targets of sustainable development goals So by the time we play a part in the areas of yours, we play a part in other areas, would have helped the entire world move closer to the target. Next slide. And so gradually with this, we want to thank the International Foundation for Dermatology, National League of Dermatological Society, and the Nigeria Association of Dermatologists for facilitating this training, sponsoring, facilitating, and collaborating respectively, this virtual training. I also want to thank the Ministry of Health, the NTD desk, next slide, the NTD desk for providing some of the training materials we have used herein. Next slide, please. And gradually, we have come to the end of the presentation, references, next slide, and we say hi from IRUA Specialist Teaching Hospital. Thank you.
Thank you so much, Dr. Oiwa. That was quite detailed and quite interesting. So, yes, I like the question that you asked before and at the end, that after the presentation, really need to think about it. Is it that have we really never seen a case of yours, or probably it went undiagnosed, and in our country, Nigeria, where there's, wide access to antibiotics, it's possible that, they had, in the course of buying antibiotics, to treat it, they had, it had become treated. So that is a question, but that doesn't help because we cannot trace the disease, we cannot do any surveillance or epidemiology and try to ensure that there's eradication. So it's always good if a person comes to the health center, to the pharmacy, even someone in your neighborhood or your community, say, well, I have this ulcer that's been there for a while. It's best to refer them to the hospital. And we also hope that when they are referred, the person that they see will be able to think about yours. In our environment, I'm not sure we see so much of it, but then again, we could be seeing it and we could be missing it. And that's why we are not really reporting so many cases of yours, so to speak. So I think we will ask about questions. Also to know that it's more of, I think from what you have said and from what I know about yours, it's more of a disease of children. So you see it more in young people, children, right?
Yeah, we can also see in adults, really, just like you said, maybe we're not on the lookout. Mothers and parents are always very careful. Maybe it's possible that may be why it's commoner in children, but again, cases have been seen in adults. Some of the pictures we've seen have shown adults that have had it. So I'm of the opinion that I think we may have quite some number of it, but it's just that we possibly have overlooked it or we have taken it for something else.
Okay, so let's go through the questions, the Q&A.
Yeah, Dr. Cole, are you there?
Yes, can you hear me? Hello? Hello?
Yeah, I'm with you.
Yes,
Okay, I
please
wasn't hearing
just
you for a while.
kindly go through the Q&A. Just give me a minute. I need to quickly leave, but please look through the Q&A to look at some of the questions and all. Somebody had asked, can yours spread easily? I think Dr. Gold has also answered one of the questions. So please just look through so we can discuss. And if there are any more questions, please put in the chat box. I'll be right back.
Yeah, I think somebody saying here, Oluchi Nwosu says, I'm not sure I got the initial causative organism and how it can be transmitted. You mentioned it's not sexually transmitted. The causative organism is Treponema pallidum petenue. We know that there are three treponemas. There's Treponema pallidum, there's Treponema pallidum carotium, the Treponema pallidum petenue. Yours is Treponema pallidum petenue, and basically is transmitted by contact with fluids, contact with the rash in itself, especially that yellow crust. It's typically described as teeming with the spirochetes, really. I hope I've been able to answer your question. I can't see any other questions here, just comments appreciating the presentation, which are well received. Thank you, Dr. Gold and Dr. Abdullahi, for answering some of the questions that are raised in the chat box or the question and answer area. Thank you.
Yeah, thanks. Well, I think maybe we can just read out the answered ones for those who, so one of the questions was, can yours spread easily? I mean, infectious. And of course, it's been answered by Dr. Gold. It does spread from person to person easily. And that's one of the reasons why it's commoner in children, because when they're playing, if one of them has the ulcer and they're playing, children often play with physical contact. You can spread it from one child to the other. So that is the main mode of transmission. And it's different from the sexually transmitted. They are the same organism, but different subspecies. I guess you must have spoken about that. The Yaws is the Treponema pallidum pertenue, and while syphilis is pallidum, I think.
Yes.
So they're different, but of the same family. Yeah.
So I think going through the participant list, I thought that Mr. Shilo will be here today. He's the National Program Officer for Yaws and Leishmaniasis of the NTD program of the Federal Ministry of Health. It may just have been fine for him to share one or two experiences, but I can see Mr. Afolayan is present here. And I don't know if Dr. Cole doesn't mind, we could have him maybe say one or two things in that area. I know that in very recent times, the Federal Ministry of Health has been very intentional in ensuring that many of the NTDs, especially the 13 in Nigeria, are thoroughly looked into. Training programs, training manuals are being put up, and reporting, which we can't stop emphasizing, because the problem is that you may see this in your facility and you don't know how to move ahead. Once you see it, there is a state NTD coordinator. If you cannot get the state NTD, get across to your state epidemiologist, who will be able to connect you to the state NTD coordinator. Then the state gets across to the region, the zonal, then national. And even if that may be difficult, you can get across to any of us who are the facilitators of this training, because I think that's one of the essence of this training, to get a lot of people to have direction as to where to go.
Yes, and we really want people to report more. it's not ideal that we are one of the countries where they're not sure about our status. So if we really don't have it, let's know that it's not, it's not endemic here, and as opposed to uncertainty. So the uncertainty probably will be because of lack of data. And one of the aims of this webinar series is to help to improve, data on skin NTDs. So if we're reporting more and we know the right steps to take to make reports, then we'll probably have more data and be able to be more certain to be out of the group B status that we are currently for yours. I don't know if Mr. Afolayan is on the call. I've tried to, let me try again, to add him to become a panelist so that he can speak. Let me do that again. So I think you can speak, sir. Now, good evening. Thank you so much for always being here with us for
All right.
Hello.
All right. Yeah, thank you so much. I think I've listened carefully to the wonderful teachings we do have on the platform. And maybe just to say that Yaws for us at the national program is one of the low-hanging fruits outside Guinea worm that Nigeria received a certification for. We're hoping that in the next 2-3 years, if we put our record in place, and because it just requires one round of treatment, we can proceed with all of the requirement for certification. So just to say, yes, we're in order. The FMOH within the next 2-3 months is strengthening the reporting process so that we can, have this data flow normally from the facility, be it at the primary healthcare right to the national program. And so we're also want to increase awareness as much as build capacity at the lower level so that they can do the much they can at that level and refer appropriately to the right facility where proper diagnosis need to be done. And so far so good at the national. We've not also have more like a confirmed case of yours in the last 1 or 2 years, but we're making efforts at least in the next 2 years to do all, put the necessary instruments in place and see if we can proceed to say Nigeria is no longer endemic for yours, and unlike not knowing our status currently. I think that's just all I'd like to say at the moment. Thank you.
Thank you very much, sir. Thank you so much for your insights and always being available to give your, I would say, professional or government view of the situation. So yes, we hope that in the coming years we'll be able to, have our certificates of, let's say, elimination for yours. That would be really nice. A few countries have been celebrating wins with NTDs, so we are hoping that in the nearest future we will be one of them, that can celebrate a win that we've been able to, eradicate and eliminate in a particular NTD. So there's still some new questions coming up, so try to see if we can quickly answer them. Dr. Oiwo, I know Dr. Gold and Dr. Abdullahi have been answering them also in the Q&A section. Thank you very much to those who have given their inputs. I think we should just share this for the benefit of everyone. Or all of us here can just also go to the Q&A to see some of the questions and the answers. Dr. Steve has said, congratulations for these dermatological Zoom seminars. We hope the uptakes are very high. Yeah, but we've had a bit of dwindling. Maybe we need to do more reminders. Apologies that the reminder didn't go out earlier as early as it should have this time around. So yes, he noted the need for a referral system, and someone else asked about how to refer patients. So maybe we'll just quickly gloss over that. Contact tracing, very essential. So if there's a patient, we must do contact tracing and close contacts in family and community. That's always very essential with infectious diseases, and that is the key to contact tracing and surveillance is the key to reducing the number of cases that we have. Data collection. So that's why we're hoping that more people report suspected cases if they do see them, so that they can be confirmed or refuted. Someone did say, I think, let me look for another question. Someone asked for the preventive measures to reduce Yaws. So Dr. Oiwo, I'm going to hand all these questions over to you. Oluchi was also asking about a referral system, so we can try to do that. Okay, so.
All right, thank you very much, Dr. Cole, and I want to thank the participants for the very fantastic feedbacks we're getting. So for prevention of Yaws, public health education can never be overemphasized. We do know now from that situation report of the present state of Yaws in the country. As of last year, December, we had maybe like 5 states that have been shown to report suspected cases. But as of May 31st, as it were, if I can say that, at least from my interaction with the desk officer on Yaws, we have there about 8 states that have additional 3 or 5 states have reported suspected case, but I'm not sure any of them have become positive, which is a good news. So that by, like Mr. Folayan said, by the time we do this for another 2 years and we don't find any positive case, we can just say, oh, maybe it's just uhuru for us in the eradication of Yaws in Nigeria. But it's also important for those that live in pre-endemic areas, Enugu, that had said in 1950 area, it's not impossible. Northern region, according to that map, guides us in the prevention and also guide who are people settings, and so who have ulcer. Those are not people hand other forms of that are contagious. And so all ulcers are not what you manage with your hand. So we'll tell people to prevent that. They're not all rashes, especially those ones that are referral pathway, like Dr. Abdullahi has answered. I will just re-emphasize, whichever facility where you are and you see what looks like this, please contact the nearest. If you are in the village, contact the nearest health center. If you're where the general hospital is, contact the nearest general hospital. And if you have a tertiary center where you have dermatologists there, contact them. And interestingly, digital technology is making life easier. We'll drop our mails. You can send a mail to us. May have been fine to drop numbers, but of course we do know the challenges with numbers, but mails are just fantastic. But again, not everybody can access mails. But I also think that we're able to look at the logistics of sharing numbers would also do that as well. So you get across to us. Then, like it said, every state has an NTD desk officer. So get across to the NTD desk officer in the state who will guide us appropriately along the line to Mr. Shilo, who is the National NTD Program Desk Officer on Yaws and Leishmaniasis. And Mr. Shilo is always welcoming and very enthusiastic about what he does, especially in the areas of Yaws and Leishmaniasis. So that's the ladder. But in the event that we may not be able to get this, let's just get across to the nearest hospital, the nearest facility where you have a public health physician, yes, have a dermatologist, they would be ready to guide us appropriately in that area. And to add again, please do not sit on this ulcer that keeps coming to your hospital, your pharmacy, to wherever you are, and you just keep treating. There's no heroism in treating ulcers that we do not know what the cause is. Even us as for those who are also even in tertiary hospitals, you are specialists, you are seeing this ulcer. If you are not sure, then invite the dermatologist, invite the plastic surgeons, invite the public health physician, especially when you have the relevant information to guide you in taking these steps. And we need to keep emphasizing to the patient that it is not jazz, it's not curse, it's not witchcraft. Because in normal parlance in Nigeria, once you have an ulcer that refuses to heal in 1 week, 2 weeks, it's most likely they will start tracing that place where you pressed, you masked the jazz. So we should emphasize to them that there is a name for it, there is a cure, as it were, for it, there's a treatment for it. Thank you.
Thank you so much, Dr. We're really grateful. So I'm going to put the the YouTube channel where you can get the recordings and put it in the chat box so that you can actually go back to them. We have quite a number that for those who are just joining us for the first time or have missed previous ones, you can actually look at, some of the, you can watch some of them there on YouTube. Thank you very much. So I think we have answered all the questions and addressed all the comments. Thank you very much, Dr. Oiwo, for a very didactic lecture. And we hope that in the nearest future, we'll be able to have enough data to certify us to have eradicated, Yaws in our country.
Sorry, Dr. Ford, good evening.
Good evening,
Good
Dr.
evening.
Abdullahi. Good evening.
Well, it appears somebody is asking about the Denser app. I don't know if you could just share some.
Yes. Yes. So I've actually said that you can actually send photos there. I will receive them. So we've tried it out and I think it's working now. So if you have sent something, you can also just send an email to the mail that you get the notifications from. Yeah. So I would like to see if we can put on our cameras, just take a photo. We'd like to do something for the World Skin Health, but in this webinar format, I'm not actually sure how to go about it. So I'm trying to see if that is possible, or maybe we will do it at the next one. Let's see. So I think you can only see the the speakers, but I'd like everyone to actually be visible. But anyway, I think we can start with this, and then maybe the next one we'll do the for everyone. So
maybe the next one. Most people are unable to switch on their videos like this, right?
yes, so because it's a webinar format, it's not, you can't, people can't put on their cameras. I mean, they can't put on they can't put
Their
on the
videos.
video. So
Perhaps
we
during the
can't,
next one, right? Maybe the link for the next one will.
yes, we'll
the
turn it
meeting
into a meeting. So in the meeting, everyone can put on their video, and everyone can, you can take a photo of everyone present, just to show that we have lots of people on the call. Well, we can do one for us here, Dr. Abdullahi and Dr. Oiwa, if you don't mind. So let's see. Let me just do a print screen. Sorry, I'm with the little man. Okay.
I hope I'm visible on the screen now.
Not yet. We'll just wait for you to come on.
Dr. Cole, you can see me already, right?
Yes, I can. I can see you. I can see you. I can't see Dr. Oiwa though.
Oh,
What of Dr. Abdullahi? Can you see Dr. Abdullahi?
I can see Dr. Abdullahi. Yes.
okay.
Yes,
Okay.
we can see you now.
Okay.
Yeah. Oops. Sorry, just one more minute.
The face of the young dermatologist should also show you, no?
He's not interested. It's just like my mommy. Okay, so I think I've taken a photo. Let me take one more.
Okay.
Yeah. Thank you, everyone. Please send us any questions via email. I've sent the YouTube handle for the
Recording.
for the recordings, yes. So you can actually get them from there. And till next 2 weeks, where we'll be also talking about other skin NTDs. I think we're going to be talking about chromoblastomycosis, podoconiosis, and a few other ones that are not so common here, but they're still skin NTDs, and we should know about them. And then we start thinking about gearing up for outreaches in our various areas where we can. Go to look for a community where we can go into, do a medical outreach and do skin checks for people in that community, preferably a rural area, and see if we can actually do some like case detection, find some cases, take photos, report, and also treat. So we'll be looking forward to that in the coming weeks. We'll just make it more concrete and finalize the plan. So we're gradually getting to the end of our webinar series. We hope to be able to complete it in the next 1 month or thereabouts. So thank you very much, everyone. And I wish you a
Thank you,
blessed
Dr. Cole. Thank you, Dr. Oiwa, for such a lovely presentation.
Thank you so much, and apologies for the initial glitches.
No, it's fine. It happens sometimes. So thank you
That's
so much
technology
for
for
the
you.
presentation. Yeah, can be unpredictable once in a while. Have a blessed week, everyone. Take care.
Yeah, bye.